Medicine 4. Presenting Mrs. X, a 56 years old homemaker from Tiruvannamalai, presented with fever for 10 days, cough for 10 days, breathlessness for 10 days, palpitations for last 2 days, and orthopnea for 1 day. She was apparently well before 10 days, then developed fever, which was high grade, intermittent, associated with chills, relieved with antipyretics. It was also associated with cough, which was not productive, no blood in sputum, no diurnal variation, and the cough was associated with breathlessness. Initially started as MMRC grade 1 and progressed to MMRC 3, and towards the end of the illness, it was also associated with orthopnea. She also developed palpitations at rest. There is no aggravating or relieving factors for palpitations. There is no history of chest pain, syncope, sweating, heat intolerance, diarrhea, tremors. Past history has no significant comorbidities. Family history, there is no significant family history. Personal history, there is no addiction. Post-menopause for last 10 years. Clinical examination showed a blood pressures of 140/80 at time of admission with a heart rate of 148, irregular heart rate with a pulse deficit of more than 10. Her respiratory rate was 26 per minute with an elevated JVP. There is no pallor, icterus, clubbing, cyanosis, no lymphadenopathy, and no edema noted. Cardiovascular system examination, normal S1 and S2 was here. There is no murmur noted. Respiratory system examination revealed a slight tracheal shift towards the right side. No tenderness over the chest wall. However, there is a dullness over bilateral infrascapular and infraaxillary area. There was also decreased breath sounds over bilateral infrascapular and infraaxillary area. Abdomen was soft and non-tender. CNS examination showed no focal neurological deficits. Summarizing, 56 years old female with no comorbidities, currently presented with fever, cough, breathlessness, palpitation, and then later developed orthopnea. With examination findings of irregular heart rate with elevated JVP and bilateral decreased breath sounds over infrascapular and infraaxillary area with dull note and percussion. The differential consider as a clinical syndrome of heart failure with atrial fibrillation, and etiology thought in view of fever with cough where infections such as pneumonia and myocarditis, pericarditis, valvular heart disease, and ischemic heart disease. With this differential, we evaluated the patient, and the initial investigation showed a ECG with a low voltage complex with low voltage complex with absent P waves and irregular rhythm, suggesting atrial fibrillation, and the low voltage complex suspicious of pericardial effusion. And the chest X-ray showed a classical water bottle sign with which is also favoring of pericardial effusion with bilateral pleural effusion. For confirmation, we have done an echo which showed a moderate pericardial effusion. So at this point, the differential considered for this bilateral pleuropericardial effusion, where even the heart failure per se can cause a severe congestive cardiac failure can per se cause this pleural effusion with pericardial effusion. However, other differential we consider where the infection causes such as tuberculosis, viral etiology, and non-infectious causes such as autoimmune disease like SLE, rheumatoid arthritis. However, there is no other systemic history or signs suggesting of autoimmune disease. Malignancies like metastatic cancer such as lung cancer, breast cancer, primary lymphoma can also present with pericardial effusion and pleural effusion. The metabolic causes such as hypothyroidism can also present with pericardial effusion and pleural effusion. So, approaching the patient with went ahead with pleural diagnostic and therapeutic thoracentesis and pleural fluid analysis based on the algorithm. The initial cytology showed a WBCs of 390 cells with lymphocyte predominance of 51%. Then pleural fluid 14 was 3.8 with the pleural fluid LDH 249. The ratio of pleural fluid protein and serum protein was 0.55 with this pleural fluid and serum LDH ratio 0.37. Going with the algorithm, it fulfilled it met the Light's criteria favoring exudative process. And then we did the pleural fluid glucose. However, it didn't meet this criteria of less than 60. Our pleural fluid glucose was 126. And we then did a close ultrasound guided pleural biopsy. And also we have sent fluid for cytology. And both the pleural fluid cytology was negative for malignant cell. In addition to, we have sent a pleural fluid expert and MG, those were also negative. Pleural fluid biopsy also showed no granuloma or malignancy. Or the pleural fluid ADA was little elevated, 22. And we have also done a pericardial fluid diagnostic pericardial synthesis, and the fluid was sent for analysis, which showed cytology showed a lymphocytosis with no malignant cells, and ADA was elevated 73 units per liter. So now we have a pleuropericardial effusion, which on further evaluation showed exudative, mostly lymphocytic predominant effusion with the elevated ADA in both pleural fluid and pericardial fluid. So what could be the most likely differential in this setting? Yeah, in this country like India, developing country, the first differential we usually consider is tuberculosis. However, tuberculosis is not the only differential to consider at this point. Our patient's immunophenotyping showed features suspicious of B-cell non-Hodgkin's lymphoma. So what is the role of adenosine deaminase? ADA. ADA is a useful tool in diagnosis of TB due to its high sensitivity and specificity. But however, TB is not the only disease that presents with elevated ADA levels. ADA is essential enzyme in purine pathway of DNA metabolism and is widely distributed in tissues and body fluids. But its main reservoir is lymphoid tissues and particularly T lymphocytes. This in TB associated TB associated pleural effusion, the ADA is elevated because there is large number of T cells mediating inflammatory process. However, those lymphoma infiltrating the pleural space will also lead to increased lymphocyte count. There also we can note a consequent ADA elevation. This is a case report where elevated adenosine deaminase in pleural effusion. Case of non-Hodgkin's lymphoma was misdiagnosed as ATT, TB, and started on empirical ATT. In this patient, the thoracocentesis yielded a pleural exudative effusion, markedly elevated adenosine deaminase and LDH. However, the pleural biopsy showed non-specific inflammation of pleural tissue without malignancy, granuloma, or acid alcohol resistant bacilli, and the pleural fluid cultures were negative. And the patient was started on empirical ATT. 2 months later, patient presented with worsening breathlessness. Chest X-ray was repeated. Effusion was persisting, and then they did flow cytometry analysis that identified anomalous lymphocyte, and the immunophenotype characteristic of which supported the diagnosis of diffuse large B-cell lymphoma. And this is a study that compared differential diagnosis between lymphoma-associated malignant pleural effusion and tubercular pleural effusion, where all consecutive patients diagnosed with lymphoma-associated malignant pleural effusion and tubercular pleural effusion between January 2011 and December 2016 were retrospectively studied, and they compared the clinical symptoms, laboratory findings, and pleural fluid data such as serum lactate, LDH, C-reactive protein, pleural fluid, ADA, and comparison showed no much of a difference between ADA among both diagnosed with lymphoma-associated malignant pleural effusion and tubercular malignant pleural effusion. However, there is some positive association in serum LDH that is noted in the study. In the patient presented with lymphoma-associated malignant pleural effusion had positive association with LDH. With the risk ratio, with the predictive p-value of less than 0.01. So learning points: elevated ADA levels are not pathognomonic of TB infection. Lymphocytic predominant exudative effusion, always better to rule out malignancies.
Any comments or questions?
See, ADA is not to confirm the diagnosis of tuberculosis. Okay? It just means the presence of activated T lymphocytes. So it's useful for its negative predictive value. And in a institution like ours, we should always strive for microbiological confirmation of diagnosis. Second is that you are saying that this lady has pleural and pericardial effusion. There's nothing else. Even on imaging, there are no lymph nodes, no erythrosplenomegaly. CBC is normal. You are calling it a lymphoma. So primary effusion lymphoma again is an extremely rare diagnosis. Occurs in like PLHIV with very advanced immunodeficiency. And your cytology has not confirmed the diagnosis. So don't call it a lymphoma yet. Maybe a lymphoma. So we still now don't have proof to say this is.
We'll move on to our next presentation by Dr. Gladys, maliciously febrile.